My name is Dr. Amoussou. I'd like to go over the role of the neurohospitalists in the management of seizure today. In the past, we have talked about stroke management for the most part. I think we need to switch things around a little bit. So today is going to be about seizure management and EEG monitoring. So I have no disclosure. So my objective today is to discuss ways to optimize the treatment of a new onset seizure and to go over the management of convulsive status epilepticus versus non-convulsive status epilepticus in the ICU. The point is not to go over the algorithm that everybody know about, but to realize that we don't need to use the same approach toward convulsive status epilepticus and the same approach toward non-convulsive status epilepticus. I'm also going to go over the role of continuous EEG monitoring and the need of epilepsy monitoring unit, which we are working toward developing here. So let's start with electroencephalography. So this is a very important tool that we use in the management of seizure disorders. It allows us to determine if a patient is actually having an actual seizure or not. So with the EEG, we can record the electrical activity generated by the brain. And this will give us a real-time clinical information on brain function. We can use it to determine if there is a focal lesion in the brain, or it can also help us assess the mental status of a patient. We can tell the degree of encephalopathy a patient is experiencing in the ICU. So with EEG, we can determine the level of coma in a patient, whether they are in light coma or in deep coma. And it's an important tool that we use in the ICU to help the intensivists manage the patient. Coupled with video, we can actually assess the behavior in epilepsy monitoring unit to decide if the behavior that we see is actually seizure or not. We can also use this to localize or find the focus of seizure activity in the brain, which can help with surgical planning if needed. So I'm going to go over the indication of continuous EEG monitoring. So any patient with abnormal mental status who is in convulsive following convulsive status need to be monitored to make sure that they are not going into, they are not in subclinical seizure. We also use this to ascertain acute supratentorial brain injury with altered mental status. Any patient with unexplained fluctuation in mental status need to be monitored to make sure that they are not experiencing non-convulsive status. So when we order routine EEG, we may see abnormal activity including periodic discharge. And with such a finding, we need to get a prolonged study to determine if this pattern is going to evolve into ictal pattern or seizure activities. And we also use this in a patient with high risk of seizure who are on paralytics. And lastly, we use this to monitor response to anti-epileptic medications. So what is seizure? So seizure is defined as a transient change in behavior due to an abnormal, excessive, and synchronous neuronal activity in the brain. Seizure is not a brain disorder. It can be a manifestation of a systemic illness like sepsis, metabolic disorder. It can be due to alcohol withdrawal. We also see this in primary brain processes such as meningitis, but this is not a disorder. It's a symptom of whatever brought the patient in. Epilepsy, on the other hand, is a disease of the brain defined by any of the following conditions. At least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure and the probability of further seizure similar to the general recurrence risk after 2 unprovoked seizures, which is about 60%. And any patient with at least 2 seizures in the setting of reflex epilepsy. Reflex epilepsy is the type of seizure that is triggered by external stimulation, such as flashing light, video game, or stereotypic sound. So I'd like to, okay, join this. What's the pointer? Pointer? What is the pointer? Yeah. Okay. So I just want to explain the rationale between why you need to have 2 seizures 24 hours apart. So they did this population-based study in 1988 that looked at 72 patients who presented with more than 2 seizures within 24 hours. And they compared them with patients who presented with 1 seizure within 24 hours. And they followed this patient over 5 years, and the risk of having seizure recurrence was not different in the 2 groups. That's why they based part of the definition on less than 24 hours. So you can have as many seizures as you want, as long as it's within 24 hours, it's considered as 1 seizure. Now, the incidence of seizure is pretty high. So 10% is the risk in the general population. And of those 10%, 4% will go on to develop the diagnosis, or will have the diagnosis of epilepsy at some point in their life. But the actual prevalence of epilepsy is pretty low. It's about 1 to 2%. So knowing that the side effect of seizure medication can be pretty severe, we need to be prudent on when to start treatment. And for that, we need to confirm the diagnosis and then determine what the risk of seizure recurrence is in a specific patient to help them decide whether they need to be on medication or not. So to help with the risk assessment, we need to gather good information and do all the workup to assess a patient's risk. We need to know if they have a history of prior seizure, any family history of seizure, any developmental delay, meningitis, or trauma. And we need to do a complete workup and LP if needed, if you are concerned about possible infectious process. I prefer MRI, especially in adults, because we have a better resolution. We can see small lesion in the brain, and routine EEG to help stratify the patient for risk of seizure recurrence. So we need to take in consideration this factor. What type of seizure did the patient have? And how many seizures and over what time? We also need to consider the risk of seizure recurrence and what are the consequences of seizure recurrence. A patient who is in a nursing home may not need to be on seizure medication right away, whereas a pilot or a truck driver might need to be on seizure medication. So we need to take into account those factors. The type of seizure is going to affect the risk of epilepsy in the future. And this is very important. We some people may like to put everybody on, anybody with seizure on seizure medications. And that's not the right approach. We need to determine their risk of having seizures. So acute secondary seizure are not epilepsy. Somebody who has a provoked seizure, which is defined as a seizure due to systemic illness, sepsis, or bacteremia. It could be alcohol withdrawal, medication side effects, and some antibiotic can increase or can lower the seizure threshold, and people can have seizure as a result of that. So those people should not be on long-term anti-epileptic medication. There's an exception to that. A patient, somebody with bacteremia who is on antibiotic and then start to have seizure, he need to be on antibiotic for 6 weeks. So we can treat that patient with anti-epileptic medication until they complete the course of antibiotic, and then we can stop the anti-epileptic medication. So the second type of acute secondary seizure is the acute symptomatic seizure. This type of seizure occurs in the setting of acute primary brain process such as encephalitis, subdural hematoma, brain tumor, or TBI. And this group may need to be treated for a short period of time, but there is no evidence to support long-term treatment. So a patient who comes in with a stroke and has a seizure on admission doesn't need to be treated long-term. In fact, some people with subarachnoid hemorrhage are treated between 3 to 7 days, and then you can stop the seizure medication. The risk of having seizure in the future is not different than the general population. Slightly is about the same to some extent. But the key point is to treat the underlying condition. But patients who have unprovoked seizures are more likely to develop epilepsy. And we call this type of seizure remote symptomatic seizure. And this is the type of seizure that people developed. They have a seizure, and during the workup, we found a lesion in the brain, small stroke that they have maybe 10 years ago, or some other processes. So with that type of seizure, we may need to have a lower threshold to start treatment. Epilepsy syndrome needs to be treated. Patients with juvenile myoclonic seizure need to be treated because they are going to have seizure in their life. So there is no question about that. Same thing for Dravet and other epilepsy syndromes. And I'm going to focus on the remote symptomatic seizure because this is the one we deal with often, and we don't know how to approach this type of seizure. So Dr. Alan Hauser, he's a neurologist. He did a lot of neuroepidemiology studies, and he had shown that the risk of having two seizures, the risk of having subsequent seizure after one unprovoked seizure is much greater, and this patient needs to be treated with anti-epileptic medication. This study was done in 1998. He looked at 204 patients who presented with a first seizure, and he followed them for 5 years. And the risk of a subsequent seizure was 33%. And then after having the second seizure, the risk increased to 76%, which is very high. So at that point, we need to, decide when to treat. Do we start treating after the first seizure when you see, like all stroke or encephalomalacia in the brain? Do you decide to treat after the first seizure, or you wait until they have a seizure recurrence before you start treatment. So that's a difficult question to answer. So there are other studies that help answer that question. This is another interesting study. They look at patients who presented with acute symptomatic seizures, like could be TBI, meningitis, subdural hematoma. They presented acutely with seizures, and the risk of mortality was 10 times greater at 30 days compared to a patient who presented with unprovoked seizures, who have a remote traumatic process in the brain. But if they manage to survive after a month, the risk of mortality at 10 years is no different than patients who were admitted for unprovoked seizure. But the interesting thing is that the risk of having seizure in 10 years is 80 times less than people who have unprovoked seizure on admission, which is pretty interesting. This look at people who presented with acute stroke and have seizure, acute TBI with seizure, and acute CNS infection with seizure. They look at them and compare them with people who have remote seizures. Remote unprovoked seizures. So the risk of somebody who presented with acute stroke and have seizure, the risk of having a subsequent seizure is 33% compared to 71% with unprovoked seizures. Same with TBI, the risk is much higher, 46% compared to 13%, and 63% compared to 16%. And the conclusion is that acute symptomatic seizure is not epilepsy, and they don't need to be treated. People who present with remote symptomatic seizures, the remote unprovoked seizure need to be treated. So we need to decide when should we start treatment. Do you start after the first seizure, or you wait until they have the second seizure? Somebody, to answer that question, did another study. So they divided this study into arms. They treated the first arm immediately, and the second arm of the study only receive seizure medication after they have a subsequent seizure. And the finding is that people who were treated immediately, they have the time to the second seizure was much greater compared to people who did not receive treatment. So treatment actually delay the time to have another seizure. It also delayed the time of having focal seizure and the time to grammar seizure or generalized tonic-clonic seizures. And we don't want people to have seizures, so maybe it's a good idea to treat early. It also showed that the 2-year remission is reduced with early treatment. But the overall conclusion is that early treatment is not going to prevent your risk of having future seizure in the future. The risk is still the same. The only thing okay. Hello? Okay. So the benefit of early or immediate treatment is that it's going to prolong the time the patient is going to have a subsequent seizure. And it's going to reduce the remission time. So that's the benefit of early treatment. Now, to help us in our decision making, they design this model is a prognostics model that was designed to help determine people who should be started on anti-epileptic medication early and those who should wait. So they look at the number of seizures at presentation, and they get 0, 1, and 2 points. For any neurological disorder or MRI finding, they get 1 point. Abnormal EEG get 1 point. So low risk was assigned 0. Medium risk was assigned 1 point. High risk 2 to 4 points. So the finding is that people with low risk have little benefit to immediate treatment. So there's no point to treat early treatment in people with low risk, whereas people with medium to high risk may benefit for early treatment. In fact, when you look at the way they score the low risk, you can take your patient. If the patient presents with 1 seizure, normal MRI, normal EEG, 0 points, there's no point to start treatment. Whereas if the patient presented with 2 seizures, 24 hours apart, they get 1 point, you may decide to start treatment. So this can help. This is actually makes sense in terms of how we approach seizure management anyway. And this graph only illustrates that patients with immediate treatment on the left, high risk is the dot. So, and the y-axis is the probability of no seizure. So the high risk tend to have a seizure early, compared to the delay treatment, which is on the right. Low risk is at the top, the solid bar. So just to summarize this, first unprovoked seizure with normal MRI and EEG does not need to be treated. Remote symptomatic first seizure, they have the highest risk of seizure recurrence and should be treated. So if I see a patient with one seizure, I see the MRI, there is a stroke on the MRI, the EEG shows spike and wave, I'm going to start treatment right away. I'm not going to wait for another seizure because the risk of subsequent seizure is about 76%. And the third line is that, starting treatment early is not going to change the risk of future seizures. It's only going to delay the next seizure. Now we are going to switch to treatment. So decide which medication to put the patient on. You need to take into account the spectrum of efficacy of the drug, the magnitude of efficacy, adverse side effect profile, drug interaction, ease of use, and cost. So Dr. Kwan and Brody, Australian, they run this study. They look at previously untreated epilepsy patients and started 1 seizure medication. 47% of them were seizure-free on 1 drug. Now, those people who did not respond to the first medication have another medication added. That's the second agent. 13% achieve seizure freedom. And the rest, about 40%, they added multiple agent, and only 4% became seizure-free after that. So 36% of the patients were resistant to seizure medications. So to select a medication, you have to decide carefully to minimize compliance, make sure that the medication works well for the patient, and minimize drug side effects. So most of these drugs work the same way. Newly diagnosed focal epilepsy, carbamazepine, phenytoin, carbamazepine, lamotrigine, levetiracetam, and zonisamide have been shown to work the same way. They have the same efficacy in this patient. So you just have to pick one that works well. But the only difference is that the new generation anti-epileptic drug have less side effects. So they are better tolerated. That's the only difference. So I'll always start with the new generation. I'll typically start with Keppra. That's what we do, unless there is a contraindication or the patient develop a headache or suicidal ideation or some other side effect. For generalized epilepsy, valproic acid have been shown to be by far the best. So unfortunately, there are a lot of issues with women with childbearing age may have a lot of side effects, and the fetus might be, might have some issue with that also. In fact, valproic acid have been shown to affect the cognition of a baby whose mother was on the medication. So it can cause developmental delay. So fortunately, we have a new drug on the market that can be used as in lieu of valproic acid. And this talk is not about going into in-depth in the medication selection, but rather to just give you a broad view of the strategic thinking about what to do, the steps to follow, and what medication to select. I'm sure we'll have plenty of time to go in depth on this issue in the future. So in terms of dosing, you always want to start low and increase slowly, if possible. Unfortunately, in the inpatient setting, you want to make sure that the patients are not seizing, and you want to send them out as soon as possible. So you have to keep taking into account how quickly to increase the dose versus the risk of side effect. So this is just a review of the efficacy of a few selected medication. Carbamazepine seems to work very well at 600 milligram. For valproic acid, that dose is 1,000. With 600, for instance, for carbamazepine, 80% of patients will be seizure-free. Any increase was a marginal effect, and same thing for valproic acid. You have 1,000, which is the optimum daily dose. For lamotrigine, that dose is about 200. Keppra, 1,000. Any additional increase? I personally don't like to go be above 1,500. I've done 2,000. I've seen people do 4,000 to 6,000 milligram a day. But people practice medicine differently, but the evidence shows that 1,000 milligram a day is the optimum dose. Now we are going to switch to drug resistance epilepsy. For some reason, 36% of patients will not respond to treatment. You can put them on 10 medications, they will not respond. It may be due to side effects and other issues that we are going to explore. So before deciding that the patient is resistant to treatment, we need to rule out pseudo-resistance. But drug resistance is defined as the failure of adequate trials of 2 or more tolerated or appropriately chosen and used AEDs to achieve sustained seizure freedom. We see patients who either have the wrong diagnosis, or they are on the wrong drug, or the wrong dose, or have other lifestyle issues that is affecting the seizure management. In terms of wrong diagnosis, we want to make sure that this is not pseudo-seizure. We are not dealing with pseudo-seizure, syncope, or cardiac issues. In terms of wrong drug, Dilantin, for instance, will not work for somebody with juvenile myoclonic epilepsy. In fact, some of those drugs can exacerbate some type of epilepsy, so we need to really make sure that they are on the right medication. We typically use blood level to monitor efficacy of treatment, but some people have a different blood level, and monitoring the blood level may not be the answer to that. So that's something to consider also. And then some people like, in terms of lifestyle, some people like to drink, which can affect, can interact with their medication, can cause more seizures. So a lot of things to take in consideration, just to make sure that we are not dealing with pseudo-seizure. And to really determine that, you may need to bring this patient to an epilepsy monitor unit to monitor them and see, okay, what's to determine that they're actually having a breakthrough seizure in spite of being on multiple anti-epileptic medications. And this patient needs to be referred to a comprehensive epilepsy center. In fact, when a patient fails to medication, they need to be referred to a comprehensive epilepsy center for further evaluation to see if they are candidates for epilepsy surgery or not. I know that you have referred a lot of many of the patients to UCLA and SEIZURES in the past. Now we are going to switch to status epilepticus. Generalized tonic-clonic status epilepticus is pretty well known. You don't have to be a physician to see it, right? Most of our patients are brought in by a relative because the family member has been seizing for hours. So anybody can recognize generalized tonic-clonic status epilepticus. The one that is more difficult to recognize is the non-convulsive status. And it can present in different form. You can have focal, dyscognitive, complex partial, like just confusion, acting goofy without any obvious movement, absence status, myoclonic status. This one we see this in anoxic brain injury mostly. And then non-convulsive status in the ICU. It's very important to make the distinction because we know that convulsive status epilepticus carry a high risk of neuronal damage. But in terms of non-convulsive, we don't have enough data to determine the risk of adverse effect. Obviously, you want to treat it if you recognize it, but the risk of adverse effect is still unclear. We don't have enough data to determine that. ILAE is stands for International League Against Epilepsy. So the definition of epilepsy is a prolonged seizure that might lead to a long-term consequence, including neuronal injury, neuronal death, and alteration of neuronal network depending on the type and duration of status epilepticus. So for tonic-clonic, we all know about it. It's any seizure that lasts, any convulsive seizure that lasts more than 5 minutes, or two of them occurring without returning to baseline. So when you look, the number in the time in the right is the time by which you need to stop the seizure to prevent irreversible damage. For focal status epilepticus with impaired consciousness, that definition is at 10 minutes, and beyond 1 hour, you can start to have irreversible damage. In terms of absence status epilepticus, we don't know if that causes any irreversible damage. In fact, patients were in status for weeks before they presented to the hospital and have full recovery afterwards. So the key point about convulsive status epilepticus is that it can cause severe neuronal damage. It can become treatment resistant quickly. That's why we need to jump on it and act quickly. The onset is obvious to anybody who is present. It carries a high risk of subclinical seizure. Typically, if you go in convulsive status, that means that you have a lot of neurons. You have a good brain, and you have a lot to lose. So we have to be very aggressive in terms of management to make sure that we minimize irreversible damage. And the prognosis is typically better compared to people who are in coma and happen to have non-convulsive status. We don't know if they have been seizing for a month or 2 weeks, and we just order the EEG and find out that maybe 3 weeks later, and we don't know what's going on. So for non-convulsive status, some people can be aggressive in terms of management. The key point is to realize that the risk of adverse effect is not as severe as what we see in convulsive status. I typically like to take, treat gently and make sure that the patient is stable. That's what I personally do. But I think the approach is to realize that a patient who is in non-convulsive status but is awake, talking, doesn't require to be intubated. You can see this type of seizure can present as typical absence, atypical absence, myoclonic absence, just jerking in one hand. They can have eye twitch, but they can maintain the mental status, or they can be mildly confused. Well, as long as they can protect the airways, there is no indication to be aggressive, to intubate the patient and put them on anesthetic. The other type of non-convulsive study that is more concerning is in a patient in coma. So this occurs about 8 to 20% of a patient in coma. You can be in status. They typically have a history of seizure, history of remote brain injury, or they may have had a recent neurosurgical procedure, or acute brain injury, or intracranial tumor. They might even been in sepsis. So we clearly don't know the risk of harm from having non-convulsive status. Obviously, you want to treat it when you see it, but you don't have to go all the way out to stop it. Because the seizure might have been ongoing for several days, and we only find out when you get the EEG. In fact, in some instances, the treatment might be futile because the non-convulsive status is not the primary process, but it's the result of the ongoing injury in the brain. So we can see what a patient who came in with anoxic brain injury and who we found in myoclonic status. I mean, we are not going to, we don't treat that. Some people might treat because they want to make the family, feel better about how the patient is doing, but we are not treating the patient because this seizure, type of seizure, is a marker of brain injury. So the neurons are so damaged that they don't master enough, stimulation to the body to have a normal conversion. Typically, in a patient like this, you should have a generalized conversion, but because of a lack of brain cell, they only master a small myoclonic jerk once in a while. So they cannot really master a full blown conversion. And this is a marker of poor prognosis. These patients typically don't do well. So we typically don't treat this type of seizures. And for all the non-convulsive status, the primary goal should be to treat the underlying etiology rather than trying to stop the seizure at all costs. So for non-convulsive status without coma, the prognosis is typically very good. There is no point to use aggressive anesthetic. You can just use your typical AEDs, Keppra, Vinpat, etc. Patient in coma, the prognosis is poor. But the treatment, again, should not be to be aggressive, but to make sure that we do not exacerbate the level of coma. We can use benzos and plus non-anesthetic AEDs to help this patient. Because using this medication, using anesthetic can, make the patient worse, can prolong the intubation. So for a patient who is, not in coma, you may use benzos, but mostly you want to stick with Keppra, lacosamide, or phenobarbital if needed. And this patient should be closely monitored on video EEG to see how they respond.
You didn't put Dilantin.
Okay, I can add it to the list. Okay. Yeah, you can add it. You can use Dilantin, that's fine. Okay. The point is that minimize anesthetic. Don't use it if you don't have to. So that's the point. Any patient with a new seizure need to be reported to the DMV. Every time you have to do that is, you have to do it. Otherwise, you'll be liable if something happens. Yeah, I typically defer to the ED physician and the resident, so that I don't have to be the bad guy. So that's what I typically do, yeah. So diabetes is not a risk factor for seizure.
But obstructive sleep apnea?
It's not a risk factor. But they are risk factor for small vessel disease in the brain. And small vessel disease later in life can become, a risk factor. So there is no direct correlation between diabetes and risk of seizure. But if you have a stroke as a result of diabetes, sure. But we will look at stroke more than diabetes and sleep apnea. Sleep apnea also increases the risk of stroke. But by themselves, they don't increase the risk of seizures. Yeah, so I think developing a standalone epilepsy monitoring unit will make sense, but we can use that to, for instance, wean a patient off the medication and monitor their response. Or if you want to make a medication adjustment, that will be a good indication to use that. So epilepsy monitoring unit serves several purposes. And surgical evaluation is one of them, but we use it for other purposes also. I think that will be beneficial. It will be beneficial to have that system here so that we can manage patients more appropriately instead of sending them to LA. The traffic is pretty bad. We don't want to subject them to that. So, yeah, I mean, during my fellowship, we see a lot of patients, from Ventura and Santa Barbara. If there's no need for them to make the trip down there, that would be great. I think it would be good to have a. Go ahead.
I mean, we could just put an EEG machine with the video monitor in any room.
So that's the plan. We want to have we are not going to have dedicated rooms. We are going to have a room that can be converted into epilepsy monitoring units. But when we don't have a patient, those rooms can be used for, our typical patient. You don't have to somebody in the room, but you need to have the nurse need to be trained to recognize seizures. So they are going to have nurses anyway, right? And the nurse needs to be trained to identify seizures and how to evaluate the patient when they have a seizure. And that's all we need to do for that. So if they don't have a seizure, I will not even start it, because there is no evidence to suggest that prophylactic antiepileptic for a tumor in a patient without seizure is going to help. There is no evidence to support that. Yeah. So if they have a seizure, sure, you can put them on the medication. And after the tumor is resected, you can do a follow-up. You'll get a baseline EEG, you get a follow-up EEG afterward to see if you still have abnormal finding on EEG. And that will help you determine whether or not to stop the treatment. But I will never put a patient on antiepileptic medication without a history of seizure. The exception in TBI. So somebody with a massive, cortical injury with a skull fracture need to be treated at least prophylactically. I think that's the only study that have been shown to help